Hi everyone, let's start chapter 13, Men's Health. We're going to have at least 2 to 3 videos on this chapter. It's quite extensive. Let's first talk about nocturia and incontinence. So the definition for nocturia is frequency of going to the bathroom at nighttime. It may vary based on the volume of the urine, to having a large amount to small quantities at more frequent intervals. It's also known to disrupt the sleep cycle. So if your male patient should present complaining of nocturia, it's important to get an assessment of how many times the patient is urinating at nighttime and trying to get an estimate of the amount that they're voiding. There could be several causes of nocturia, first being a prostate problem, which is common in 50% of men over the age of 50, and that increases approximately 10% for every 10 years of age. There can be nocturia without discomfort, which may be caused by diminished bladder capacity, or the individual having an overflow incontinence issue, or could be habit. In the gentleman that has a normal bladder and the absence of nocturia while suffering from increased frequency of urination during the day, this could suggest a psychogenic origin. And a rare finding such as a polyp or an irritative lesion may be a cause as well. Also, there can be urinary incontinence. Some common causes: decreased bladder capacity, increased residual urine where the patient has not emptied the bladder completely, or involuntary bladder contractions. And dribbling may indicate an overflow issue. Less common causes may be spinal cord diseases, tumors, traumas, neuropathies. Whether we're talking about nocturia or incontinence, the causes are similar. The detrusor muscle can be unstable. Different organisms can lead to both of these conditions, such as Klebsiella pneumonia, Proteus mirabilis, Enterobacter staph, and Enterococcus or Pseudomonas. And then also medications can impact this, as can urinary retention. When working on your differential diagnosis, it's important to note the pattern of urination in a 24-hour period, and to have the patient note any factors or activities that precipitate the issues. If your patient is finding that there is an increased frequency, the primary disease, it may be primary disease of the urinary tract, or we could have metabolic issues such as diabetes. If it's urgency, it may be related to the prostate or a bladder infection. And if there's dribbling, it may be caused by urethral stricture or prostatic obstruction. If there's oliguria, it could be related to glomerular nephritis or other renal diseases. And there also can be cardiac issues that can decrease, that can decrease cardiac output. Some of the treatment for nocturia, of course, is identifying the cause. A urinalysis is performed to rule out any thoughts of urinary tract infection. A PSA and a digital rectal exam may be done to rule out a prostate issue. And then these findings may further direct further testing. Another common issue for gentlemen in primary care might be testicular pain. They may complain of a fullness or a heaviness of the scrotum. It can occur in a wide variety of patients with no differentiation. You may have, your patient can have a painful hernia that may occur when an invagination of the peritoneal cavity is occluded by the spermatic cord. And invagination is that process of turning outward, or something inside out. And also, if your patient has a patent processus vaginalis, that can predispose them to an indirect or congenital hernia. And the processus vaginalis is an embryonic development where there's an outpouching of the parietal peritoneum. And if there's partial occlusion, there can be a result in fluid accumulation or a hydrocele. On your differential diagnoses, of course, you want to find the cause of the testicular pain. You may note that there's swelling of the epididymis or the spermatic cord. There may be torsion of the testicle, and if that is noted, this is a urological emergency. A spermatocele may also cause testicular pain. Syphilitic guma is a possibility, as is a varicocele. However, these conditions are usually not overly painful. Other conditions to include in your differential diagnosis: hydrocele, variceles, epididymitis, prostatitis, hernias, hydroceles, and hematomas all must be excluded. A detailed history and physical will help direct your assessment and tell you what test to include in your workup. A scrotal ultrasound may identify a mass originating in the testicle, and then an echo texture pattern on this ultrasound reveals the presence of a hypoechoic mass, which will look different than the normal surrounding tissues. So treatment for the testicular pain will be dependent on what the cause of the pain is, and then treating that appropriately. Next, let's talk about low testosterone, and we know that these levels gradually decline as we get older, and it can be a function of normal aging or also related to hypogonadism. Other factors that may impact it are stress, obesity, tobacco, alcohol use, obstructive sleep apnea, diabetes, and illness. Low testosterone can affect many different body systems: your cardiovascular, your metabolic, your bones, erectile dysfunction, decreased libido, and then mental functioning. Normal testosterone levels are usually less than 300, and these are best assessed in the morning between 7 and 10 a.m. Treatment for low testosterone is replacement therapy, and it is contraindicated in men who have had a breast or a prostate cancer, who have nodules, untreated obstructive sleep apnea, urinary tract infections, or are a class 3 or 4 on the New York Heart Association's heart failure classification. Next, let's talk about BPH, and it's a nodular hyperplasia of the prostate, and it's very common, affecting men after the age of 40, and on biopsy it is typically seen in the transition zone. And most authorities consider not only the size of the prostate, but also the impact that it has on the urinary flow rate and the significance of post-void residuals and the bladder volume. The causes are not fully understood. There is thoughts that it can be a hormonal alteration, aging, and some genetic issues. And then there's some discussion on the role of androgens and estrogens and how the pathology of this develops. We know that it's a mechanism of obstruction, and can be the buildup of prostatic tissue, which directly obstructs the bladder neck. And also there's an increase in the prostatic muscle tone, which can lead to constriction of the bladder neck, which all impacts urinary outlets. Subjectively, your patient may feel a decreased force in their stream. They may have hesitancy. There may be post-void dribbling, the sensation of not being able to empty completely. They may also mention the inability to voluntarily stop their urine stream. They may have to double void, straining. Some irritative symptoms may include having to go to the bathroom during the night, frequency, urgency, dysuria, and incontinence with urge. So some objective findings may be on your digital rectal exam that there is enlargement of the prostate. Most times we describe the prostate as about the size of a walnut, so you may notice enlargement of that. And there also can be hematuria noted, observation of a weak stream, and then also note bladder distension. Diagnostic tests that you might perform start with a urinalysis to assess for the pH, and that will tell you a little bit more if there's been a chronic residual urine issue. And if there's obstructive uropathy, then the creatinine may be elevated. A PSA in your benign prostatic hypertrophy is usually less than 10. And the literature also mentions the prostate health index, which is a new test for the detection of prostate cancer that combines the total PSA, the free PSA, and another PT PSA to give an indication of the chance of prostate cancer. Other tests, oops, went too far. Other diagnostic tests, well, excuse me, you might consider a urine culture, as sometimes they can be positive for bacteria because of the chronic residual urine, and then urine cytology can be done to rule out a carcinoma, especially if blood is noted. Diagnostic testing, you might consider an IVP, and that's going to tell you several things, whether you're having an increased post-void residual volume, if there's the impression of a large prostate on the bladder, a trabeculated bladder, which is referring to the texture of the muscle, and it loses its elasticity. There can be upper tract dilation. There can also be bladder stones. If your initial workup does not yield the results that you are looking for, there may be the need to consult a urologist for further testing. And some of those tests might include a uroflow, a cystometrogram, or a cystoscopy. Other differential diagnoses for BPH could be a bladder outlet obstruction. There could be non-obstructive etiologies, and the irritative symptoms could be the issue. On page 648 in the book, 13-.1, there is a complete differential diagnosis chart for BPH. Now, medical management is going to be based on the symptoms. So if it's mild to moderate, you're just going to be watchful. As lifestyle changes may change based on the AUA score. And this is the American Urological Association score for symptoms. It encourages the avoidance of caffeine and alcohol. And then with a high AUA score, with urinary retention and or complications of BPH, then more vigorous treatment may be considered. These might include the addition of some medications, such as your selective alpha-adrenergic agonist, and then a subtype alpha-adrenergic receptor targets. And those medications are listed there. There's also your 5-alpha reductase inhibitors, and then there's complementary therapies that may be helpful. And those are listed on page 649 and may include saw palmetto, cranberry extract, things like that. If all of your conservative measures do not meet the needs of the patient and their symptom management, then there may be indications for surgery, and that could be sustained urinary retention, intractable symptoms because of prostatic obstruction, obstructive uropathy, and then recurrent and persistent UTIs and recurrent gross hematuria caused by the enlarged prostate. And of course, those are being sent to a urologist. Some of the procedures that may be considered might be a TURP, a transurethral incision of the prostate, the TUIP, an open prostatectomy, and also a robotic simple prostatectomy. So some minimally invasive procedures: a TULIP, a transurethral laser-induced prostatectomy, coagulation necrosis, laser surgery, and then transurethral electrovaporization of the prostate. There also can be ablation procedures. You could have stents placed and a balloon placed. Follow-up is important, and it's important to assess for the AUA symptoms every 1 to 6 months. They may have urodynamic testing done every 3 to 6 months, digital rectal exam and a PSA yearly, and any patient with BPH who is suspected to have prostatic carcinoma should be referred to a urologist. Education is important, that patients are advised to avoid over-the-counter medications that contain alpha agonist or anticholinergic agents, which can cause urinary retention, that can also lead to renal failure. And these include medicines such as Benadryls, over-the-counter Parkinson meds, Cogentin, For your alpha agonist medicines, those may include medications like clonidine. So educate your patient on those. They should also avoid things that might irritate the bladder, such as coffee, spicy foods, or alcohol, and they should be instructed to avoid at least every 2 hours to help the possibility of a UTI. Next, let's talk about erectile dysfunction, and it's sometimes referred as impotence, and it's the failure to consistently maintain a rigid erection to allow for sexual intercourse, and it's also considered part of a male sexual dysfunction. ED can also manifest as a lack of sexual desire or the inability to ejaculate. To classify it, it might be considered mild if the patient fails to be able to achieve an erection in 2 out of 10 attempts. It may be classified as more severe if all attempts at an erection fail, and then moderate erectile dysfunction is somewhere in between both. As you can see on this slide, it is fairly common. Between 15 and 30 million men are believed to suffer from ED at some point. More than 25% are over the age of 65. And it can happen in about half of all adult men at one time or another, and it is not pathological. Most causes have an identifiable cause as opposed to psychogenic cause, and if it can be a failure to generate the nerve impulse that is required to initiate erection. There can also be loss of libido, which may indicate an androgen deficiency, and then medications that the patient might be on could be adversely affecting their performance. So I'm not going to go over the pathophysiology, but the next few slides are going to talk about the 5 phases of sexual function in men: libido, erection, ejaculation, orgasm, and demusence. Be sure and review these in the PowerPoint. On clinical presentation, your patient may present with loss of desire. They're definitely going to have the inability to obtain or maintain an erection. There may be premature ejaculation, absence of emission, or an inability to achieve orgasm. Objectively, you're going to want to do a genital exam and palpate the testes. You're also going to want to assess for any feminine characteristics such as gynecomastia or abnormal body hair distribution. It's important to palpate all pulses, including the penile pulse. And if there's an indication for vascular etiology from the patient's history and physical, that needs to be explored, and an aortogram may be indicated. Other tests may be needed to assess impairment of the vibratory position, tactile, and pain sensations of the penis. It's important to do a neurological exam to evaluate the erectile reflux, including anal sphincter tone, perineal sensation, and the bulbocavernous reflux. And you can review that in your physical exam book, and also in your book on page 654. It gives a brief description of the exam, but you would be squeezing the glands of the penis and noting the degree of anal sphincter constriction. You will also want to do an exam for any signs of peripheral neuropathy, including distal muscle weakness and any loss of tendon reflexes in the legs. Diagnostic test to start off with is to assess for diabetes and rule out any elevated blood sugars, do a lipid profile, a TSH, and to check for a testosterone level. Other tests might include a CBC, chemistries, and a PSA in gentlemen if they have a family history of prostate cancer. Some other specialized tests might include a nocturnal penile tumescence and rigidity test, and a Doppler sonography of the penis. Your differential diagnosis can be varied. You could have fibrosis secondary to trauma, severe urethritis, late-stage syphilitic lesions, benign or malignant tumors, urethral strictures. So management is going to be dependent on what the cause is found. You may be discussing with your patient behavioral sex-based therapies for non-organic causes and hormone replacement if necessary. Non-pharmacological interventions include vacuum constriction devices, vasoactive therapy, penile prosthesis, prosthesis, and penile revascularization. For follow-up and referral, hormonal replacement therapy should be guided by someone who is used to giving testosterone and is familiar with how these patients need to be monitored. There may be a need for referral to a sexual counselor or a marriage and couples counseling. And then invasive surgical interventions require referrals to urologist or to a pelvic surgeon. Patient education. It's important to stress the management of chronic conditions such as high blood pressure, diabetes, and stress, and how they can impact erectile dysfunction. Guided imagery, regular exercise, yoga can be used to help reduce stress. Good control of blood pressure and blood sugar, and then counseling for any psychogenic causes of erectile dysfunction. Our next section is going to be prostatitis, but it is quite lengthy, so I think this will be a good place for us to stop with part 1 of chapter 13. We'll be back shortly.